Hello everyone. So today we'll be talking about management of third stage of labor, and the third stage is one of the most crucial stages of labor and previously uneventful. First and second stage can become abnormal within a minute with disastrous consequences in third stage. And the principle of underlying the management of third stage are to ensure strict vigilance and to follow the management guideline strictly in practice so as to prevent the complication, the important one being the postpartum hemorrhage. The two method of management are currently in practice. One is active management, that is preferred one, and next one is expectant management. And first of all, talking about the talking about active management of third stage of labor, AMTC, TSL, the underlying principle in the active management is to excite powerful uterine contraction within 1 minute of the delivery of the baby, and by giving parenteral oxytocin, and this facilitates not only early separation of the placenta but also produce effective uterine contraction following its separation. And its advantages of the active management of third stage of labor are it helps in the minimization of the blood loss in the third stage approximately to about 1/5, and it shortens the duration of the third stage of labor to a half, and it reduces the maternal anemia, and the less need for blood transfusion, and less need to manage postpartum hemorrhage, and all these all are due to the minimization of blood loss. And the more and uh, only disadvantage is the slight increase in incidence of retained placenta in 1 to 2% case, but it is only in 1 to 2%, and a consequent increase of incidence of manual removal. And accidental administration following delivery of the first baby in undiagnosed twins produce danger to the unborn second baby caused by asphyxia due to tetanic contraction of uterus. So it is essential to limit its use in twins only following delivery of the second baby. And the use of oxytocin decrease postpartum hemorrhage by 60%. It reduces the need of other therapeutic oxytocin by 50%, and the active management of third stage AMTCL as such reduces postpartum hemorrhage by 60%. It reduces the incidence of PPS by 60%, and that is very great. The active management and the procedure for the active management, we have to give the injection oxytocin 10 unit intramuscular, that is preferred, and or we have the alternative like tablet of misoprostol 600 microgram, or we have the next alternative injection of methadone 0.2 mg intramuscular, and these are all given within 1 minute of the birth of the baby according to WHO. Also, after the delivery of fetus, we have to do the delayed cord clamping for 90 to 120 seconds of the birth or cessation of cord pulsation. Next step is to clamp, divide, and ligate the cord, and we have to do the to deliver placenta by controlled contraction, that is by modified Brand Andrews method, enabling the uterine contraction. Usually the placenta is expected to be delivered soon following the delivery of the baby, and if the placenta is not delivered thereafter, but it should be delivered forthwith with the by controlled cord traction, but that is Brand Andrews technique after clamping the cord while the uterus is still remain contracted, and that is the principle followed. And active management is certainly of value for the cases likely to develop postpartum hemorrhage. These risk cases are anemia, hydramnios, twins, multipara, and previous history of postpartum hemorrhage. And also and tablet misoprostol 600 microgram can be given orally or rectally in cases with home delivery, and it can be given by community health worker also. And methadone should not be used in the cardiac cases or if severe preeclampsia for risk of precipitating cardiac overload, failure in the former, and the aggravation of blood pressure or eclampsia in the severe preeclampsia cases. So how we are going to do the controlled contraction? Okay, let's try to understand by the picture how are we going to do the process of uncontrolled contraction. The palmar surface of the fingers of the left hand placed above the symphysis pubis, and approximately at the junction of upper and lower uterine segment. And the body of the uterus is pushed upward and backward towards the umbilicus, and the towards the umbilicus, while the right hand steady tension but not to traction is given in the downward. The right hand should give while the right hand should give the steady tension but not to traction is given in the downward and backward direction, holding the clamp until the placenta comes outside from the introitus. And it is also more uterine elevation which facilitated the expulsion of placenta, and uh, and this process is adopted only when the uterus is hard and contracted. So this is why how we should do the process of the expulsion of placenta by controlled contraction by left hand above the pubic symphysis, uterus pushing upward and upward and backward, while the right hand pulls the umbilicus by the gentle traction. And this is how we have to do. After controlled contraction, we have to do the massaging of the uterus to stimulate the immediately after the delivery of placenta to stimulate the uterine contraction, and this facilitates the expulsion of the retained clot if there is any. And after that, we have to do the examination of the placenta and placental membranes and the cord. And the placenta is placed in the tray and it is washed with the running tap water to remove the blood and clot. The maternal surface is first inspected for its completeness and anomalies. The maternal surface is covered with grace decidua, the spongy layer of the decidua bacillus, and normally the cotyledon are placed in close approximation and any gap indicates a missing cotyledon. The membranes chorion and amnion are to be examined carefully for completeness and presence of abnormal vessel that is indicated of succenturiate lobe, and amnion is shiny but chorion is saggy. The cut end of the cord is inspected for number of blood vessel. Normally there are two umbilical artery and one umbilical vein. Any oval gap in the chorion with torn end of the blood vessel running up in the margin of the gap indicates a missing succenturiate lobe. The absence of cotyledon or evidence of any missing succenturiate lobe or evidence of significant missing membrane demands exploration of uterus urgently. After that, the vulva, vagina, and the perineum are inspected carefully for injuries and they are to be repaired if there is any. An episiotomy wound is now sutured, and the vulva and adjoining part are cleaned with cotton swab soaked in the antiseptic solution, and sterile pad is placed over the vulva. Then we have to do the postpartum vigilance. The palpation of uterus at every 15 minutes for 2 hours to ensure uterus is hard. Estimation of blood care, and we have to do newborn care to keep the baby dry and skin contact with mother to cover the baby and the mother. Intense initiation of breastfeeding within an hour. Now we will talk about expectant management of the third stage of labor, that is the physiological. How are we going to do? In this management, the placental separation and its descent into vagina are allowed to occur spontaneously. The minimal assistance may be given for placental expulsion, and if it is needed, the constant watch is mandatory, and the patient should not be left alone. And if mother is delivered in the lateral position, she should be changed to dorsal position to note feature of placental separation and to access the amount of blood loss. A hand is placed over the fundus to recognize the sign of separation of placenta, to note the state of uterine activity, the contraction and relaxation, and to detect though rare cupping of the fundus, which is early evidence of inversion of the uterus. And the desire to fiddle with the uterus or massage the uterus is strongly condemned. That is not done, and placenta is separated within minutes following the birth of the baby. A watchful expectancy can be extended up to 15 to 20 minutes, and in some institutions, no toucher or hands-off policy is employed. The patient is expected to expel the placenta within 20 minutes with the aid of delivery, and the expulsion of placenta. Next step is expulsion of placenta. Only with the features of placental separation and its descent into the lower segment are confirmed, the placenta is asked to bear down simultaneously with the hardening of the uterus, and the raised intra-abdominal pressure is often adequate to expel the placenta. And the raised intra-abdominal pressure is often adequate to expel the placenta. And if the patient fails to expel, one can wait safely up to 10 minutes if there is no bleeding. As soon as the placenta passes through the introitus, it is grasped by the hands and twisted around with a gentle traction so that the membranes are stripped intact. And if the membranes threaten to tear, they are caught hold of by sponge holding forceps, and in similar twisting movement, the rest of the membranes are delivered. And the gentleness, patience, and care are prerequisite for complete delivery of the membranes. And if the spontaneous expulsion fails or it is not practicable because of delivery under anesthesia, any one of the following method of expulsion can be used for expulsion, like any of the given method. And that was about all about third stage of management. And